My name is Ann Quinlan Corwell, and I'm with Southern Pain Society, and I have the honor of being here with Dr. Eric Royster, who is going to present at our conference next month on March 12th, and he's going to discuss practices for spinal cord stimulation and intrathecal delivery. So welcome, Eric.
Thank you. Absolutely. Thanks for having me. It's a pleasure to always speak to you. We're looking forward to the conference in March, right around the corner.
I know it really is. So tell me, why is it important for us to discuss, for you to discuss the best practices for implantable therapies?
Well, you know, every once in a while, it's a good time to take a little time to kind of circle back and figure out what we could be doing better for these kinds of things. I mean, for most interventional pain physicians like myself, you know, these are some of the higher end things that we do. They're more invasive, they're riskier, and really more importantly, probably, you know, for these patients, patients not getting spinal cord stimulation or intrathecal drug delivery for their chronic pain condition unless they failed other things. I mean, usually surgeries, maybe multiple injections, maybe multiple medications, maybe multiple other modalities, probably multiple. So, you know, these people are, they're used to, unfortunately, failed treatments. And so when we bring these topics to bear for the treatment of these patients, who are, at least in my practice, thinking to this point, they're the most challenging patients. You know, we want to do everything we can possibly do to select the patients correctly, to do the surgical aspect side of it as well as possible. And then also, I think, the follow-up care thereafter as well as possible. And frankly, I would say 12 years into this, if you can do the first two pretty well, the last part is actually the easiest.
Ah, cool. What makes it timely for pain management now?
Well, I mean, these topics, you know, these are none of these, you know, spinal cord stimulation has been around for decades, as has intrathecal drug delivery. So you know, it's not so much that there's a new new technology that's so much out there as is a good time to circle back on what we're all doing. We're all doing it all the time, and just have a nice chance to look at some data and revisit some things that we've maybe taken for granted to see if we can't find some aspects that we can improve in our own practice.
Can you talk a little bit about the scope of of the implantable therapies?
Sure.
Because I don't know that people are really aware of that.
Sure. So, I mean, you know, these things have been around for a while, and again, because they are more invasive, they typically do involve patients who have, again, failed many of these therapies. The great indication for both really spinal cord stimulation and intrathecal drug delivery has always been failed back surgery syndrome. So for, you know, probably 90% of all the pain pumps I put in, if not more, were people who had multiple lumbar surgeries that simply didn't. They may have resolved some of their neurologic complaints, but not some of their pain complaints. And really similar for spinal cord stimulation. So these are patients who are complicated. These are patients who have not responded to less invasive therapies. And it is sort of that next higher up level of management for these patients. And so, you know, because of that, I think it's important that we make sure we revisit these topics and are always able to offer the best treatment for these patients. And probably of all the things, you know, I mentioned intraoperative, preoperative, postoperative, probably in my experience at this point, and actually the first thing, one of the first things I published on was preoperative assessment of these patients and how do you handle that? Because I actually think that picking the appropriate patients is probably the single most important thing, assuming you're also doing a competent surgical procedure.
Is that what you would say would be the most interesting part of the perioperative?
It would be for me. I mean, for someone who's not done a lot of these procedures or the surgeries that wants to learn them, there'll be plenty there to talk about in terms of the technical side of it. But I think for me, by far the most important part of these implanted therapies is picking the appropriate patient, setting the table appropriately, having the appropriate relationship and expectations. And that's something that I'm still learning even today. So that'll be a major focus.
Expectations are really important. without a
Absolutely.
doubt. Do you have a message for the people that will be attending our conference or thinking about attending our conference?
Well, sure. I think that I think I've highlighted probably the main things I'm thinking about as I'm finalizing this lecture. But there will be something for everyone. People who need to know. It's important, even if you don't know. A lot of pain doctors who very much have the same scope of practice that I have don't offer intrathecal drug delivery in their practice. They might focus more on spinal cord stimulation, for instance, which is fine. Or primary care doctors who are not terribly aware of these, or people who are not an interventional side of things. Hopefully we'll get a great sense of who you might refer, who might be a good candidate for spinal cord stimulation and or intrathecal drug delivery. We'll talk about how, as a practitioner, one might think about who might be a better candidate to go one way or the other, and how you prepare that patient in the sort of perioperative, preoperative process, which might be years, it might be weeks or months, depending. And then we'll also talk about, for maybe someone who's in a fellowship wanting to learn to do these techniques, we'll talk about actual surgical techniques, practices that are evidence-based, and then a little bit less on the the post-operative, although we'll talk about some statistics. But again, my major thrust will be, if you do the first two, the surgery and the preoperative patient selection correctly, the rest of it will actually be a very easy procedure.
It sounds like you're going to have something for everybody.
Well, I hope so. I hope so.
Thank you so much. I'm really looking forward to hearing you and the other speakers in March.
Well, thank you for taking the time. I'm excited, and I can't wait to see everybody in March.
Take care. Thanks, Eric.
Have a nice evening.
You too.